Dear colleague, my name is David Cohen. I'm professor of Child and Adolescent Psychiatry at the Salpêtrière Hospital in Paris. We are going to follow together what child and adolescent depression is and how it can be treated. This program was made under the supervision of the IACAPAP and Professor Falissard. For more details, you can refer to the IACAPAP textbook available online in open access. Let's start now with the definition. Major depression is an episodic recurring disorder characterized by persistent for at least 2 weeks and pervasive sadness and unhappiness, loss of enjoyment of everyday activities, irritability, and associated symptoms such as negative thinking, lack of energy, difficulty concentrating, and appetite and sleep disturbances. The second syndrome is patients with dysthymia that have a chronically depressed mood for at least 1 year, but not severe enough to qualify for a diagnosis of depression. Symptom-free intervals last less than 2 months. So to summarize, you have 2 diagnoses in the DSM, major depression and dysthymia. One comment on the definitions. It is often contradictory for health professionals to seek for depression in young people because a child is joyful and hopeful. So diagnosis of depression is often not considered, leading to delay in treatment. A second comment, manifestation can vary according to age, gender, educational, and cultural background. On this slide, you have the list of symptoms that are in the DSM. So the first one is depressed mood or irritability. You have also loss of interest and pleasures, weight loss or gain, or absence of expected weight increase, because you should take into account development and growth, insomnia or hypersomnia, agitation or psychomotor retardation, asthenia and loss of energy, devalorization, feeling of being guilt, decreased concentration, death thoughts, suicidal ideation, and suicidal attempts. Compared to the adult counterpart, child and adolescent depression has specificity according to age. In children and adolescents, you may be confused by irritability, for example, temper tantrum or non-compliance. Affect may be momentarily reactive. Comorbidity are very frequent. You may find somatic complaints, school problems, extreme sensitivity to rejection, and atypical symptoms in adolescents like hypersomnia or weight gain. Compared to normal adolescents, depression is present every day for at least 2 weeks. There is a deterioration from previous functioning, and high-risk behavior are common. For example, suicidal attempt. Let's see now some numbers in terms of epidemiology. Prevalence varies depending on the population, the period considered, for at least 3 months or last year or lifetime, and criteria used. Depression point prevalence is around 1 to 2% in prepubertal children and about 5% in adolescents. Lifetime prevalence is higher. For example, by the age of 16, 12% of girls and 7% of boys would have had a depression at some times in their life. Dysthymia have more or less similar rates. Female to male ratio is equal to 1 in prepubertal children, but in adolescents you have more female than male. Depression increases among patients who suffer from chronic mental condition, developmental disabilities, and in indigenous minority children like Native Americans, Australian Aborigines, and so on. There are many risk factors for child and adolescent depression. Here on that slide, we summarize history and psychological risk factors. I will insist only on few of them, like family history of bipolar disorder, like the presence of comorbidities, whether it is chronic medical illness or psychiatric disorder. I will also insist in terms of psychological factor on low self-esteem, trauma, behaviorment, and losses. We are still on the risk factors, and very important at the family and social risk factor in child and adolescent depression: abuse, neglect, negative parenting style, parental mental disorder, parent-child conflict, also bullying, this is very important with peers, child and adolescent offender, institutionalized or foster children, refugees, homeless, asylum seekers. Suicide is a major risk in depression, and you need to know in the context of depression the risk of suicide. Risk of suicide is correlated with the number of previous suicide attempts. Risk factors of suicidality in the context of depression are numerous, and some of them are listed in this slide: drug abuse, health problems, behavioral problems like running away or stealing, school problems and refusal, anxiety, depression severity, depression with psychotic features, isolation and or rejection, severe family dysfunction, and poverty. On that slide, I give you a developmental view for child and adolescent depression that tries to summarize what have been said previously. On the bottom line, you have the age from infant to young adult. Then, in terms of symptoms, the younger the child, the more somatic and psychomotor symptoms are present, and this is the case in infant depression. The middle line gives you an idea of dimensions that you need to consider in terms of psychological development, which are mentalization, moral and guilt, self-esteem, and existential questioning that are more present in older children and adolescents. And the top line gives you an idea of the risk factor that are social factors and also other risk factors that are more present in adolescents. Let's now move on treatment of child and adolescent depression. When a clinician assesses a child with depression, the first question he needs to answer is, do I have to propose an hospitalization? You may think of it in case of severe depression, oppressive suicidal thoughts, suicide planning, or suicidal attempts with a desire to repeat it, depression with psychotic features, patients isolated, and patient or family incapable of corroboration. Of course, proposing an hospitalization depends also on local facilities. The second question is, when should we prescribe an antidepressant? The first treatment option in child and adolescent depression is psychotherapy. However, prescriptions are warranted in some cases. Medication is indicated only in the severe cases. From the many studies available, you should prefer fluoxetine 20 mg per day in monotherapy. Improvement occurs within 2 to 6 weeks in 60 to 70% of the cases. Duration is at least 3 months, and prevention of secondary effect is warranted, particularly for increased suicidal ideation. You should plan regular meeting with the patient and the family, and always associate a psychotherapy approach. And stopping medication should be progressive. An important aspect when treating a child with depression is to consider non-specific predictors of treatment response. And I try to summarize them in that slide. They are the therapeutic alliance, the professional empathy, the patient's motivation to change, and compliance. And I should remind that risk factors for non-response to treatment in child and adolescent depression are very similar to the risk factor of non-compliance in pediatric care that have been studied in chronic disease such as asthma or diabetes. There are family dysfunctioning, brief meeting sessions, parents not satisfied of the doctor in charge of their child, and so on. Let's now move to psychotherapeutic approaches. As I told you, psychotherapy is the first line option, and it is the core treatment of child and adolescent depression. Interpersonal psychotherapy and cognitive behavioral therapy are superior to control condition at short-term outcomes, but all structured psychotherapy are similar at long-term follow-up. In that slide, the figure refers to a large meta-analysis that was published in World Psychiatry, the journal of the World Psychiatric Association, showing the importance of psychotherapy in treating children and adolescent depression. We are now going to go through some psychotherapeutic approach. First, cognitive behavioral therapies. Behavioral therapies uses some kind of behavioral training and psychoeducation. Cognitive therapy uses some kind of cognitive restructuring training. Their program asks youth to examine automatic thought and core schemas and to assess the accuracy and effective consequences of their views. They are aimed to teach youth to engage in rational thinking about themselves, the world, and their possibilities for the future. CBT is a combination of behavioral therapy and cognitive therapy. Additional CBT skill building techniques are used in many programs by teaching relaxation techniques to cope with environmental stressor, providing social skills and resolution training, and teaching general problem solving. I will add that when relaxation is used, it also helps to follow more the emotional feelings because it controls anxiety. Interpersonal psychotherapy aims at educating patients as to how their depression and the quality of interpersonal relationships affect one another, and at addressing interpersonal problems that may be contributing to depression, for example, grief, disputes, role transitions, social deficits, and so on. Compared to its adult version, interpersonal psychotherapy in youth is shorter, involves parents, and adds a liaison role for the therapies between schools and families. Psychodynamic therapy proposes patients to help to understand the origin and nature of long-standing problems by investigating both conscious and non-conscious thoughts and emotional feelings. Psychodynamic therapy uses free association and interpretation of dreams or drawing in children, and addresses how personal history and experience may alter the patient therapy's transference. In youth major depression, a particular interest is given to psychological trauma, early parent-child relationship, narcissistic organization, and experiences of loss. In clinical practice, supportive psychotherapy are probably the most frequent therapy used. However, there are unstructured therapy without specific psychological techniques, but they help people to ventilate their experiences and emotion and offer empathy. These therapies are commonly described in the literature as either counseling or supportive therapy. The last psychotherapy I wanted to mention is family therapy. Family therapy works with families to nurture change and development. It tends to view change in terms of the systems of interaction between family members. In the case of youth with major depression, family therapy aims at helping the family to answer the child's needs for completing age-appropriate developmental tasks to relieve depression. Since we are doing this program for the IACAPAP, it is important that the last slide regards cultural aspects, given the number of countries that we want to share with this program. You need to know that in some culture, expression of major depression may be masked by shame or family concern. Also, in some culture, people are reluctant to accept the idea of child depression, even more than in Occidental culture. In low-income setting, other approaches than structured therapies might be helpful, for example, support groups, body mediation activity, like relaxation or practice of sport. Also, group psychotherapeutic sections have been used in mass traumatic events with some success. This was the case in post-ethnic violence in Uganda or post-earthquake in Haiti.